To the October 29th, 2020 COVID-19 Clinical Grand Rounds special session on home health, EMS, emergency department, and critical care. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 emergency department and critical care and EMS home health challenges and successes. If I'm preparing for COVID-19 patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Struminger, Amanda Dazan, and Amy Amistad for the peer-to-peer learning platform we use for these rounds. This is our 83rd clinical rounds that we began on March 24th. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Monday, November 2nd will be EMS rounds. Those rounds will be on PPE issues for EMS and COVID with focus on cold weather operations. Tuesday, November 3rd will be critical care rounds on diabetes and COVID-19. Thursday, November 5th will be emergency department rounds on suicide of physicians during the pandemic. Stay tuned for announcements for future rounds. We are working and striving really hard to balance our schedule and topics for rounds with the challenges of clinicians who are fatigued, increasing number of COVID-19 cases, and feedback from all who participate in the rounds. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These clinical rounds and NETEC's webinars are complementary to each other. I'm going to now turn this over to Dr. Bruce Struminger with Project ECHO.
Thank you, Rick, and welcome everyone, particularly our participants. There are almost 225 participants who've joined us so far today, and special welcome to our guest presenters and our expert panelists who've been joining us on this journey for the past 7+ months. Just going to go over a few housekeeping items. So hopefully everyone can see my slides. We love getting questions and comments from the participants about today's presentation. So please put those in the Q&A feature of the Zoom along the bottom of the Zoom toolbar to the right. We'll be monitoring that for your questions and comments. If you have any technical or logistic issues, please address those in the chat function, and we'll also be monitoring that. Rick will be asking a crowdsourcing question in a few minutes, and please put your response to that question in the chat. We are recording this session, and your attendance is consent to be recorded. Thank you for that. Today's presentations should be linked to the announcement that went out this morning from Project ECHO. We will also be archiving them on our HHS ASPR Clinical Rounds website, and we'll share a link to that for you. The recording will also be archived there, and the recordings of all the 80+ sessions that we've had since March are there, along with the PowerPoint presentations. We are offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. There should be a link to that in the announcement, and you have up to 48 hours to complete the survey. We'll also share a link about 15 minutes before the end of the hour. We really appreciate the feedback that you share with us. It's all anonymous. It helps us guide planning for future sessions and hopefully quality improvement of this initiative. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep them apolitical and non-commercial. Well, thank you for that. Also, just a note about data. We really appreciate the data you share when you register, when you answer the polling questions, when you offer responses to the polling question and the crowdsourcing questions. And we want to ensure you that we take data stewardship seriously. The data we share with Rick is all de-identified and anonymous. As Rick mentioned, NETEC, the National Emerging Special Pathogen Training and Education Center at Emory, is a partner in this initiative. And we want to highlight the webinar series that they've been hosting since March as well. They have several upcoming webinars, one on influenza and in the age of COVID, which will be tomorrow. So we really recommend you try to attend that. There's going to be a session on acute renal failure and COVID-19 next Wednesday, and care transitions to home health next Friday. They also archive all their recordings, so please check out their website. With that, I'm going to share the microphone with Dr. Rosha McCoy with the AAMC to give us an update on their clinical guidance repository. Rosha.
Thank you, Bruce. Yes, I want to remind everyone of this resource from the Association of American Medical Colleges. We have continued to update this site with clinical guidance. We just updated this week. So there are some new links in the repository. We hope this is helpful. We're continuing to get steady interest in the site and people are using it. So we're happy that it's helpful to clinicians and we'll continue updating it. Thank you.
Great, thank you, Rosha. Rick, back to you for the crowdsourcing question.
Thank you. Many of you who participated on the rounds before are really familiar with our crowdsourcing questions. We learn a lot from each other in seeing the responses to these questions. And obviously, given we're focused on home health today, I think it would be really helpful if each of you could have respond to this one. What experience have you had with home health during the pandemic that all clinicians could learn from? And even if it's no experience, put that in there. Just learning what our experiences have been, I think will help a lot. So with that, I'm gonna first, I just wanna recognize and appreciate our panelists for joining us today. In particular, new panelists to the rounds representing home health, Ken Albert, Brent Corte, and Dean Chalios, and I hope I pronounced it anywhere close to what they should be. Panelists have been invaluable in our rounds and really appreciate your joining and representing home health. We also have, I extended an invitation to panelists or speakers from our previous rounds and really welcome them as well. Indeed, healthcare is really complex, and having the opportunity to bridge multiple disciplines and sectors of the healthcare system through these rounds is really helpful and I think important to all of us. With that, I'm going to turn this over to our first speaker, Linda Tanner. Linda is president and CEO of VNA Health, and she's coming to us from Santa Barbara, California. So Linda, please.
Thank you. I'm so excited to be here, and it's still morning on the my coast. So I'm gonna try to get my PowerPoint up. Let's see here, share screen. Of course, it worked a few minutes ago.
No worries. We've all been.
I know, this is horrible. Hang on. Share, I don't know what's going on. I think because we went, wait, wait.
We're close. Yeah, it says you're at the end of the
Okay,
session.
okay, wait a minute. I just saw it a second ago. Wait,
No
wait.
worries, no worries.
Okay, here we go. Let me just get here in the beginning and get the first slide. So this is a little stress provoking. Anyway, I'm Linda Tanner, President and CEO of VNA Health, as was said in Santa Barbara. We have home health and we also have hospice and an inpatient facility. So we'll get started here and talk a little bit about what some of the challenges. I also serve on the board of our California Association for Home Care. So I have a perspective from the industry in California. So first of all, some of our challenges, workforce. In the beginning, as you all know, and there was a lot of fear. So there was fear on the part of staff, there was the fear on the part of patients. So we were down staff in the beginning. People weren't sure, if they wanted to work, they were afraid. They were also afraid for their families. If they weren't afraid for themselves, they were afraid for their families. That's not different from other healthcare. And then of course, people needed to work from home. We did close down our offices, not completely, but we definitely had over half of our people working from home. And as you know, that's challenging, just the same challenges across healthcare with children, schools, having space, and of course, technology. So
Hey, Linda,
yes.
for just 1 second, we're not seeing your slides. Would it help?
Oh, you're not.
It's okay. It's all right. I mean, if it's
Well, let me hit share again if I can. I am so sorry.
no worries.
You guys might have to put them up.
Amanda, maybe if we can try pushing, maybe. There we go. Here we go.
You got it?
Just let them know which slide you want to be on.
Okay, we're on the first slide. Industry
Great.
challenges, workforce. Sorry. Okay, so
That's okay.
So working from home, and then of course the other part that was challenging was technology. So we transitioned a lot of our departments home. Medical records completely worked from home. Intake worked from home. Our clinical staff rarely came in the office only to get supplies, and so we needed to make sure that everybody had the technology they needed in order to process records and take intake and communicate. So we did that pretty well, but again, not all home cares had that technology. I'm a member of many groups across the United States, plus in California, and some of them, they didn't even have cameras on their computers so that they could do Zoom. So that was all things that they had to do, and they needed to supply printers at home and scanners and things. We were in pretty good shape that way, but we definitely had to up it, and our IT department had to work very quickly. And then of course we had clinical staffing shortages, as I've already talked about. People that elected not to work right from the beginning, they were too afraid, and so they actually went on leaves of absence. And then our home health volume fell significantly due to no elective surgeries. So that was a huge financial impact. And luckily we had hospice, which our volume did not drop, but for agencies that are home health only, this was a really big hit. Volumes fell anywhere from a third to a half. So then the other challenge was, of course, as all of you have talked about, was PPE, resources and training. In the beginning, getting PPE was really challenging. As part of home health, we're a little bit at the bottom of the food chain sometimes. And so we weren't first of mind, as hospitals, as should have been, were obviously first, in medical groups. There was some price gouging. So a lot of things that were not that expensive became very expensive. And prior to some of the government financial resources, there was no dollars to cover this. So again, if you didn't have some kind of a reserve, this was really hard. And then for the N95 mask, there was an expectation that you do fit testing. And I think that even took us, we knew about fit testing. We were very lucky. We did have a couple people trained to do it, and we had the kit, but not all agencies had that. But we still weren't ready. When we got our first presumed positive case, we weren't able to take the first couple because we hadn't gotten all of our staff fit tested. And so that was an issue for us that we quickly solved. And then, of course, regulatory confusion. As you all know, there was all kinds of different, and there still is, regulations coming out because we're all learning. So this is not meant as criticism. It is just that we were all doing the best in the situation and we're all learning. So, but there was just constant changes. And so it required, we had in the beginning daily meetings with our leadership, frequent meetings with our county. And then staff were, when the staff that did volunteer to go out, really, we very rarely use gowns out in the field. And so they really needed new competencies in donning and doffing of gowns. We made that became a mandatory competency along with them going through new infection control training, just to be sure that they were safe. So staff safety was a paramount concern, which required a lot of PPE and a lot more training. Next slide. Unless I'm next slide. Did you guys get that?
Yeah, we're on industry challenges, testing of
Yeah.
staff.
Yeah. So testing of staff, of course, that also was a challenge. It was insufficient resources, very limited availability of from labs of kits to test. There was community testing sites, but in the beginning, those were very full. And here in California, anyway, the wait was very long to get the test results back, which really created a lot of problems. So if a staff went into a patient's home, patient was needed to get tested with a presumed potential positive, then we had to keep all of any staff that had seen that patient had to be for 14 days, had to quarantine or get a test and at least wait that 7, sometimes 10 days to get the test result back. And any other patient that staff member had seen, we had to go out and do the same thing. So this became really problematic. It was very expensive. We did train our own staff to do the testing, but then we had trouble getting the kits. And then the other problem is there's a lack of rapid testing sites here and a lack of rapid testing kits. So I'll talk a little bit about that later. And then as we do test staff now, and I am talking a little bit on the hospice side, but in order to go into a SNF facility, we have to now test our staff every week for any staff that go in. And so that's pretty much all of our hospice staff because they on call. And so the tracking of all this testing, so we do the same thing for our home health, we test them monthly, and all that tracking is pretty much a nightmare. And then accessing facilities during COVID, assisted livings, congregate livings, and SNFs there was a lot of fear out there, and some of those congregate livings were hit really hard with positives and media and those things. So they were very fearful and they didn't want to let staff in at all. They were confused. Our county came out and told them they needed to let us in if we were taking care of patients. They really didn't want to do that. So there was just a lot of back and forth and fear, constantly changing directions about visitations and discharge and transfer guidance. So lack of consistency. I already talked about the weekly testing required, and then the limited resources for use of full PPE. We made the decision on our own that any staff that was going to go into any facilities would just wear full PPE because we wanted to protect our staff, but we wanted to protect the residents of those facilities from our staff in case one of our staff tested positive. So even though there was a cost to that and it was going through more PPE, we just felt like that was a really good thing to do. And I really am very proud and happy to say that we, to date, have had no staff contract COVID through work. So we've had a few through home, but we've been really careful and have used our PPE. Next slide. Again, industry challenges. Federal and state emergency blanket waivers. So the federal government came out with some really great waivers for home health that were very helpful, the 1135 blanket waivers. Those were in conflict with our Title 22, which is our state regulations. And California was really slow with regulatory relief. So and it was so confusing for our agencies out there because they're hearing from the federal side that there's waivers and that, we now can do these things. But in our Title 22, our state regulations, that was not the case. So that just got resolved in September when our state finally came through with similar waivers. And so that was really confusing, very, very, very slow. But I would like to say that I do appreciate that CDPH worked with us through CASA, our California Association for Home Care Services, regarding the blanket waivers and flex waivers. So we've gotten that resolved now. But as an example, we put in for a waiver in March, and we never did get it until the blanket waiver came out from California. And then telehealth is great. And there was a, federally, that we were allowed to use this. Patient were fearful of staff coming into their home, particularly in the beginning. They didn't want strangers coming in, and I so can appreciate that. So we tried to use telehealth where we could. We were fortunate in that we had a telehealth program already set up. So that was helpful. And then we also resorted to using Zoom or GoToMeeting with our patients. But there is no reimbursement for that. So I don't want to get into the weeds here, but home health gets paid by the episode, and you need to do a certain number of visits. So if you substituted telehealth for those visits, you were really hurting yourself economically. And so we'll talk a little bit about successes next. So some of our successes was our county health department here in Santa Barbara County. They were truly amazing, but that was not the case across the state because of some of my positions across the state, I was able to talk to other agencies. And so our county, we had a scarce medical resource group and a request process. And so we were able to obtain quite a bit of PPE through our county. They were very forthcoming when they had PPE. We got a percentage of that. So we were really grateful for that. We were on phone calls with them, sometimes 2 and 3 times a week in the beginning. Now those phone calls are still weekly, where we're on with other providers. And so we really are kept abreast of what's going on and all of the changes in the regulatory guidance. And then we serve on some county committees. We serve on the Santa Barbara County Disaster Healthcare Coalition Advisory Council. We serve representing home health on the Scarce Medical Resource Committee. And we also serve on the Public Health COVID-19 Vaccination Planning Work Group. So those collaborations have been critical to us as an agency, getting the resources we need. And so I feel very blessed that our county thought of home health and invited us to participate on those committees. And then I will say also as a success that home health is very uniquely situated to handle a remote workforce. So our workforce was already remote. So our staff had laptops and iPads already. They were used to working out of the office. They just work out of the office more and come in less now. We did add remote video capability for them that they didn't have before. We did, in the beginning, particularly limit their face-to-face contact with patients to just essential visits using our telehealth. And as I said, we had entire departments that were able to work from home. Some of our successes also was our PPE inventory and order management. We centralized our supplies in April, putting one person across all in charge of all COVID supplies. We developed a tracking system. We were able to see our burn rates. And I'm happy to say we currently have a 6-month supply of inventory because we don't know what the fall is going to bring, and we don't want to get in that position where we don't have enough PPE. We did the mandatory infection control training, so our staff has been safe, and we've kept staff safety as a priority. So we feel like we've had a lot of successes and have handled this well, but we are kind of at the end of the continuum, and it would be great to be more included in some of the regulatory things up front. So looking ahead, next slide, last slide. Financial resources. So we want to make sure that home health gets included in, any kind of financial considerations from the government, because we get paid for our home health services, and our primary payer is Medicare or Medicare Advantage. And so what we get paid is set, but this is all an extra cost. So I've been told that the PPE is running anywhere from $10 to $11 per visit. And so that's an extra cost for all these agencies to absorb. And there is a financial impact to this. PPE, we want to make sure that it's a priority for us. And I know there's been a lot in the news around skilled nursing facilities, but it's just as much a priority for home health because we're walking into homes. I mean, we're going into environments, our staff are, where we have no idea what they're walking into. Family members can be there. There may have been, they may have had a contact that we're not aware of. So our staff are at risk every time they go into a home, and many times they see 5 or 6 patients in a day. So if they have had a contact and then they go to other patients, so PPE is really a priority for us. And then point of care rapid testing in the field. So I know that the federal government is sending out a lot of kits to SNFs, but I think home health should also be included in that. Again, we are going out, we would love to be able to test our patients when we go out rapidly to make sure that there's, that they're not exposing our staff and vice versa, of course, our staff. And then vaccine prioritization. I know there's a whole plan around that. I know healthcare workers are high in the priority, but I'm hoping that home health is right up there because we do take care of vulnerable elderly patients. The majority of our patients are over 70, and so they are very vulnerable out there. And then reimbursement for telehealth, of course, is extremely important to us. And I am happy to say that there was a bipartisan home health emergency access to telehealth HEAT bill that's been introduced just last week in the Senate. So we'll see where that goes, but that would give us during this COVID crisis some reimbursement for the telehealth. And then I just want to say, as we look forward into healthcare and where we're going, choose home. I mean, patients, some patients need to go to SNFs, but many patients could be taken care of in the home with home health. We're already set up for it. We have the different clinicians that are able to care for them, including therapies and speech and aides and social workers. So going forward, I just hope that we think of home as one of the solutions to our healthcare problems. So that was really quick, a lot of information, and so that's it.
Linda, thanks very much. I learned a lot, and I think many, based on what's going on in the chat and questions and so forth, I think there's your presentation was extremely informative. Well, I'm going to just do one question from that I've seen in the QA and taking a look at the chat and so forth, so on. The are your providers caring for post-COVID-19 or patients who've been discharged with their principal diagnosis being COVID? And what's sort of like, okay, if so, a lot of them, a few of them?
Yes, we do care for post-COVID-19 patients. I would say we've had a few of them, not a lot of them. We've had quite a few presumed positive patients that we've not necessarily come out of the acute care, but they've had exposures, or they have come out of acute care, but they, we're still not sure that they are not COVID. But when we've gotten the testing done, many of those patients have not been positive, but we have taken care of some positives. We treat it all the same if they're presumed or if they're positive. Of course, everyone's wearing full PPE out there. And that's a lot of work when you have to don and doff the gowns and the gloves and everything every time you go into a visit. Then you have to step out of the house and then do it again and then do it 5-6 times a day. So yes, but not a lot. So many agencies across the country have had a lot more COVID patients than we have. But home health as an industry does take care of a lot of COVID out in the community.
And I'm curious, based on one of the sort of a quick follow on, we've talked on rounds before, particularly in the emergency department series, some in critical care as well, about embedding essentially hospice-like resources in emergency departments and critical care units. And have you had the circumstance or are aware of the circumstance where home health is actually providing hospice care for COVID patients?
Well, because we have a hospice, we would send our hospice team in.
To the right. Okay. Thanks. Appreciate that.
Yeah.
So,
but I will say, let me just back up on that. Home health does sometimes keep patients that are end of life because they don't want to transition to hospice. They don't want to lose their current team. So it does happen. And our staff are all able to do that.
Yeah, thank you very much. And thanks for your presentation. We'll have a chance to talk some more a little bit later. At this point, I'd like to introduce our next speaker, Kathleen Sullivan, Vice President of Post-Acute Services with Dignity Health, and believe she's coming from Yorba Linda, California, I think.
Oh, thank you, Rick. And I assume everyone can hear me fine?
Yeah, and slides are up and looking great. Thank you.
Awesome. Well, no, I'm sitting here in northern Santa Barbara County today, and it's kind of interesting because both Linda and I are in the same county. So I think it's important to paint a little bit of a picture about that. Santa Barbara County within California is about halfway between San Francisco and Los Angeles. And on a scale runs maybe about halfway in the pack of the counties in terms of incidence. Last I looked this week, Santa Barbara County had maybe 9,800 plus COVID positive tests, which gives you a sense of the volume compared to LA or Riverside, et cetera, nowhere near. But most of those incidents have been in North County, which is where my office is, and took, I'd say, probably the bigger part of the brunt. So when I was thinking, okay, now I can move them. When I was thinking about a few things just to share in a short time, the things that I found of greatest impact were in this area of human resources, all the new information coming, the breadth of communication required of all of us, the impact to our own health, and of course, PPE, which you could spend a day talking about. But under human resources, really it was staffing. In the beginning, the governor, which was great in his wisdom, issued very quickly a mandate for stay at home. So we had staff who were of a certain age or who had their own underlying health conditions or were the caregiver of others, and they ended up taking leaves or having, in some cases, to retire. We have very robust health policies, which further affect staffing, because with a large organization, there are going to be staff of all levels who have exposures in the community. These are all community exposures. And then they have to report every single day, take their temperature, do the screening. And if they have any symptoms, they go to employee health and they're put off. If they have an exposure from a party they attended, then they are evaluated and put off for 10 days plus. That can create havoc with your staffing, but it's very, very important to stay very rigorous with that. And engagement. You know, last night we had our very first employee awards recognition, which is important, all by, in our case, Zoom, a virtual employee recognition. You have to be very attentive to an already remote force to try to keep them engaged while they are suffering through their own life experience with social isolation. All this new information, and Linda got into a lot of this, but from the California Department of Public Health, Medicare, OSHA, accrediting organizations, your state and national trade associations are right, Johnny, on the spot, providing lots of guidance and information. I am a board member for the National Association, as are several of my colleagues on this panel. Common Spirit, which we belong to, again, a lot of work around guidance and missives and policies. And so our job on a daily basis was to be on 15 phone calls as a leadership team and analyze all these variations and apply and change process and educate. Zoom fatigue happens. Do any of you understand that? I think you do. Now, but we press on, we find new ways. It's our new normal. Some of this is going to stay. Technology overload, as Linda said, we also appreciated the waivers relative to HIPAA, could now use iPads, could serve as the bridge to doctors for patients who couldn't get into their office or were afraid, and allow access that way. That has been very helpful. Communication, huge, huge. Down there is a picture of our beloved Dr. Kadix. We did a film, The Commercial, where the whole purpose in this commercial airs frequently on the stations in these towns we serve, the hours where seniors are watching. And it is all about what we do as an organization, home care, to prepare, dress up our staff, what they'll expect when we come into the home, and why what they're going to receive is safe. So stop refusing us coming into your home. It is safe. You want us to come. And by the way, you're not going to your doctor. We will be your doctor's eyes, and we'll link you to your doctor until you feel safe going back there. We activated our incident command system. It stays activated because we're healthcare system based. We're also part of that. which is a big plus. I cannot thank the powers that be enough to be so closely associated with incredible physicians up here associated with the hospitals in the north part of the Central Coast. Our epidemiologist, infectious disease doc, and pathologist who ran the labs were so visionary and got volumes of testing platforms in early. We don't have to wait for tests. It's been an incredible gift. They've been extraordinary. The impact, as Linda said, impact to organizational health. We had the impact of the P&L like everybody does. The productivity drops while you're training and while you're doing things slowly and thoughtfully, and you're working through different staff. You're reaching out to all the traveler companies to keep coming in to backfill. Our volume didn't drop for long though. It came back actually fairly quickly. And gosh, we saw so many things in the community that are part of our obligation, that part of affect our entire organizational health. Food insecurity was incredible. So we overnight pretty much set up our first food pantry, which was great. And we have home health, hospice, and home infusion as the backbone of our home care programs here. And we cover the 2 counties. Again, addressing all the needs in the community, it has been a challenge, but we're firing on all cylinders. We did not mobilize home. We were prepared to do so. Our intake and other critical programs were prepared to go home, but we didn't. All the essential workers stayed on the workplace. We did have to do some construction, keep our 6 feet, et cetera. And then the access to PPE. I know there's lots of questions pending, so I'll close here. I think there are many conversations. Yes, PPE was a nightmare. Yes, we jumped in and we got into extended use. We never got into reuse. The purchasing, we had streams from 3 different sources, from the public health department, from the organization, from the hospital, from our own line with our own supplier. Continues to be critical to stay on top of that. But I will close here and be happy to answer any questions.
Thanks very much, Kathleen. A question, this one's sort of a big picture question. Today, as in October 29th, what's the biggest, the greatest challenge that you're facing with home health, that you're facing today? The greatest challenge that you got?
I think 3 things. I'm sorry, 3 things. The fatigue, the COVID fatigue factor, to stay new, to stay vital, to remember that this is to some degree our current normal, and that all the preparations were laid. We know what we're doing. We need to stay on top of things like PPE. We need to stay on top of changes, regulations. We're still on conference calls, but this is normal. So get back to the strategy. Get back to the growth things that we wanted to do. If we have an extensive palliative care program. We were in the process of building a contract with a payer who wanted to pay for it. That got put on hold. When every bit of your leadership team is devoted towards addressing a new crisis, it has to get out of crisis at some point in order to do that. And some of us, depending upon your surges, won't necessarily get out of that crisis. And then staffing. Staffing is the biggest. Staffing in general in California is a challenge. In our part of the state, it can be a real challenge. And keeping those people in the workforce, keeping them safe, helping them in the community, educating, constantly, do not have parties, you take care of sick people and screening them. So those are the biggies.
Thanks very much. Paul, are you available for a second? Yes?
Yes, I'm so sorry. I got pulled away.
No,
from
that's
the call.
okay. That's okay. So as I've mentioned sort of at the top, one of the advantages of having so many disciplines here is some shared potential shared experience that can help each other. I think both Linda and Kathleen, you certainly kind of nailed it, the challenge with the information overload. It was fascinating. The rounds we held, we did a special rounds on remdesivir a couple of weeks ago. And in that rounds, Dr. Paul Bittinger from Massachusetts General had a slide that caught our attention, certainly at HHS, but I think the participants really caught on to it as well. A way, one approach to that information overload. And I just want him to share that so you got the advantage of listening to others about that one. Paul.
Yeah, thank you. And I'll post the link in the chat for everybody. So, you know, I do think it's almost impossible for everybody to keep up with so much changing research and treatment guidance, et cetera. And so we created a dedicated team that was multidisciplinary with nurse, physician, pulmonary critical care, renal, cardiology, other experts to try and sift through the literature updates and process them in a way that very busy, very harrowed clinicians would be able to understand quickly. And it's got, at least from my biased perspective, a nice balance of being simple, that you can get kind of the quick points if you only have a minute of time, and a fair amount of good reference and literature citation in it in the middle, if you really want to, you know, dig in and chew on the discussion. So I'll pop it into the chat. It's a resource that's available free to anybody that can sign up if you want to on the website. And I think you know, for all of us in our different areas, trying to find ways or find teams or partnerships to help with that is extremely important. I know you know, in all sectors, whether it's you know, home health or emergency care, pulmonary critical care, we're still learning about both, you know, best practices as well as what the evidence supports. So you know, I think I really appreciate the presentations. I apologize, I had to get pulled away in the middle of Kathleen's great presentation, but you know, really amazing work and incredible description of the challenges. And thank you so much for the great presentations to Linda and Kathleen.
Yeah, thanks, Paul. Here's the plan. I'm trying to get to where we absolutely end at 1:15 p.m. Eastern time, and sort of like try, because I mean, these presentations have had a wealth of information. My plan to get to 1:15 between now and then, I want to do the polls now, and then Dean, Ken, and let me see, Brent, I'm going to go to you after the polls to provide your comment. Ken, I want you to talk about PPE. Each of you realize we got about 10 of us on here, so you got to like be quick to the point. And then I want to turn it over to our other panelists from the other disciplines for their comment or questions. And then we'll end with Linda and Kathleen for the final word. So if our colleagues with polling, Echo, could we like go ahead and pull that one up? Okay. For those of you who haven't done our polls before, if you can jump on these as quickly as you can, that way we've got more time for discussion. And in terms of the polls, we don't identify individuals as in who responded that way, not at all. We de-identify these. Everyone gets to see the results, panelists and the speakers and myself. We're not able to respond to the polls, so they're not biased by any of us. And yes, these poll results are shared with HHS ASPR as well. So let's see. And they'll be up on the web anyway, so what the heck? Nobody has to ask permission for these. All right, 47% have voted. Like to get some more, like to get at least a 50% with these. For that individual that's involved in many different disciplines, pick your favorite, the one you spend the most time in, I think. And Dr. March, I see we're going to get you on earlier than later, okay? All right. For those of you that haven't been on the rounds before, we are all busy. People have to pop in, pop out based on what's going on clinically, and then trying to like lead some of this stuff. So we're really flexible with that. All right, let's stop there. 62% have voted. That's great. That's great. Let's see who's on. Quite a distribution. For you in home health providers or administrators, clearly there's some interest by some other types of providers in what you're doing out there right now. All right, next. As of today, COVID-19 vaccine and vaccination plan information shared with clinicians is more than adequate, or less than adequate? All right, whoever hadn't done this before, you're getting on it really quickly. I appreciate that. It's very helpful. Uh, 58% have voted. I'll go for another. I'd like to get at least 60. Okay, another 5 seconds. And just to tee up what's going to happen, I think the next ones are all going to be, this is going to be a little bit different from many of the polling. We're just going to have these for the home health care providers or administrators, those involved with home health, respond to the following ones. It'll give us a good visibility on the challenges, successes of home health. So, all right, 61% have voted. Let's stop there. 3% indicated more than adequate, 24% adequate, 73% less than adequate. All right, let's move to the next one. Okay, this is for health providers, administrators, et cetera, et cetera. I'll just read the question. You can see the potential responses. Today, what is your greatest challenge related to infection prevention and control, program administration, or training? And each of these questions today, unlike some of the rounds, each of these have only one response per question. Dr. Strominger, I think after like 83 of these, I ought to be able to be a board exam writer. This is fascinating. I mean, actually, all right. Give it another 5 seconds. Yeah, wait till you see these results. How about this? All right, let's stop. Quite the spread. Looking like testing capacity seemed to be the highest one in terms of frequency of response. All right, next. For home health only, today, what is your greatest challenge related to PP access, use, or reuse? I do want to put in just as a, yeah, it's a plug. When I say plug, it's resources that have been developed through the National Emerging Special Pathogen Training and Education Center on donning and doffing and PPE. Highly recommend those to, those resources have been pulled together by that center, which is comprised of Bellevue Hospital, Emory University, and Nebraska Medical Center, and supported by our taxpayer dollars. All right, we'll stop there. All right, PPE shortages by far one, and then other is 30%. For those of you that put in other, if you can put in your chat, like other was X, because yeah, obviously I missed the other ones as categories. All right, next. Yeah, Echo, if you can put up the next one when you're able. There we go. Again, for home health, which of the following PPE supplies are you most short of today? Kathleen, while people are responding to this one, just as a sort of point of information, you mentioned the fatigue. For awareness, over the past months, we've been tracking in these polls, fatigue, complacency, and the mental health support challenges for healthcare providers across EMS, emergency department, and critical care. And they are profound challenges. So know that that is shared among acute care providers. So don't feel alone with that one. All right, let's stop there. N95, adequate N95 masks was the most frequent response. And again, for awareness, that tracks exactly with where EMS, emergency departments, and critical care have been over the past, I'd say probably month or so. This same question has been asked of each of those disciplines. Early on, like back in April, May, so forth, so on, adequate N95 masks was the biggest shortage in these polls. Then that started to gowns, and now we're back to N95s. All right, next. All right, today, what is your greatest challenge with staffing, again, for home health? Another 5 seconds or so. All right, let's stop there. With staff shortage being the highest by far. Wow. Staff shortage. We've actually done rounds on workforce issues and staff shortages and the challenges with that. And because this is our first with home health, didn't get into deep dive about why that is and some of the challenges. Yeah. All right, let's go to the next one. I think we're getting really close to the end. So panelists sort of like be primed to know where your unmute button is. Today, what is your greatest challenge related to home health? Same question I asked of Kathleen after her presentation. And yes, this is the final poll question. Great. Thanks, Amanda. what I'm going to do based on scheduling, schedule issues, so forth, so on. The first person I'm going to ask to comment is not home health, but Dr. March, since he's got to go probably for clinical reasons. And then I'll go to our home health panelists and then to our other panelists and then to Kathleen and Linda. All right, let's stop there. Staff capacity or support looks like to be the most frequent response. All right, thanks all for participating. I know that was a new experience for some of you. Well, not the polling or doing exam questions for sure, but doing them during rounds may have been a new experience for many of you. So I really appreciate you jumping in and doing that. All right, Juan, please comment.
First of all, thank all the speakers for an excellent presentation
Oh,
today.
who are you, Juan? Juan.
Hello, my name is Juan March. I'm an emergency physician and EMS physician. I'm a professor with the Department of Emergency Medicine at East Carolina University and chief for the Division of EMS there. I will say that due to RN shortages, many hospitals, when their census is high, have a tendency to discharge patients with COVID home on the early side. They go home with home O2, with anticoagulants, and also with home monitoring. And as Dr. Bittinger already mentioned, there's a lot of research on COVID, but there's very little research regarding home monitoring of COVID patients. And something all of us need to do, whether we're speakers, panelists, or participants, is to support, promote, and encourage research to determine the risks and benefits of home monitoring of these COVID patients, because we're going to be seeing a lot more of them over the next few months. We need to determine risks based on age, sex, their pulse ox reading, maybe their D-dimers. We need to also use and encourage mobile integrated healthcare, community paramedicine, because there's clearly a shortage of healthcare professionals. And I believe this is a group that potentially can assist with this process. And this involves not just post-hospital discharge, but also pre-hospital admission. There's many COVID scoring systems out there. SREC-4 is just one of many. And again, I just want to encourage folks to help promote that research so that we might all benefit. Thank you all very much.
Thanks, Juan, and have a great shift. Dean, I'm going to go to you, and then I'm going to go to Brent, and then Ken. Dean.
Thank you, Dr. Hunt, and thank you to HHS and ECHO for including us. I'm Dean Chalius. I'm the president and CEO of the California Association for Health Services at Home, serving the home health, hospice, and home care industry in California. And I just want to, again, emphasize that home health, hospice, and home care as well is a very critical aspect of the healthcare continuum. And while sometimes we're an afterthought, I think this pandemic has really brought to the fore the importance of what we do, how we do it, and where we do it, and the comfort, safety, security, and familiarity of people's homes. One of the things that is a challenge for us, and I think we've been somewhat successful so far, and we need to continue in this vein, is to make sure that home health is prioritized, whether it's PPE, testing, regulatory relief, or even government financial assistance for agencies. We have frontline workers going into homes in very dangerous situations. Of course, they all have their PPE, and I thought it was interesting that my friend Linda mentioned that it's $10 to $11 a visit. Every visit additional for our agencies when they go in to serve these patients. So when I first heard that we were going to be linked with emergency medicine today and folks that are serving in emergency departments, I really thought about it. And the nexus is absolutely direct. You see so many patients come into your emergency departments with multiple comorbidities and really sick people. They're there for an acute problem, obviously, but it's important for everybody in emergency medicine to understand what we do and the resources that are available when you discharge these patients and or just send them back home. So again, Dr. Hunt, thank you for including us. I don't want to take too much time, but we really appreciate being here and look forward to doing this in the future with lots of other groups. So thank you very much.
Thanks, Dean. Yeah, just a personal observation. I actually don't think, practiced in emergency medicine for decades before this particular role. I don't think emergency docs ever have thought about home health as an afterthought. Rather, it's there. Don't know much about it, but it's a huge, really important resource that we probably should know more about, and this may have served to help with that. So thanks, Dean, for bringing that up. So let's see, Brent, I couldn't find you. There you are. Right next to Dean, sorry.
Hi, yeah, Brent Corti, Chief Home Care Officer at Evergreen Health in Kirkland, Washington. I also have the honor of serving on the board of the National Association for Home Care and Hospice with Kathleen and Ken, who are on this call as well. I work for Evergreen Health, and we had the first death in the United States. So we all know that Washington State had COVID came early to Washington State. It happened to be that the hospital system that I work for had the first death, and we had either the first or among the first dozen or so patients admitted to home health and hospice. I got the call on February 28th at 10 p.m. I'll never forget it. And we were sort of thrown into this world very early, and have learned a lot from not only our hospital, but from our folks in home health. Just one big consideration. I want to make sure, I know Ken's going to focus on PPE, but all of a sudden when COVID came, America became homebound. So what we do, and I think Linda mentioned this earlier, but what we do is largely mobilizing a remote workforce that takes care of homebound folks. So knowing that we all sort of became homebound, many of us have still had to show up. I know that pretty much everyone on this call has likely been out there providing care to folks, but our family members, other peers and neighbors are stuck at home. Our role is to keep people away from UED physicians, to keep people out of the emergency department, to keep people from unnecessarily going into the hospital. And we've been working very, very hard to do so. When we consider PPE, to not cover home health or hospice or any other aspect of skilled healthcare is essentially putting everyone else at risk, knowing that we are out there in the community providing that care. One thing that is a huge consideration, and this may be more food for thought, but we very early March had to consider, I suppose it's a medical ethics question or just a question of general morality. What is the fine line between providing home health care and providing hospice and going out in the community and helping these patients, and on the other end, being a possible infection vector? And this was an extremely difficult thing for everyone, from our hospice physicians to me as the leader of our enterprise to come to grips with. And I can tell you that what we have found is that the more we're out there, the more we act as the front line in the community for homebound folks, and sharing that work with EMS and emergency physicians and a number of other folks, the more we've been able to keep people from having to go into the hospital. And that's been a tough thing to rationalize. Many of our clinicians have said, I don't want to go provide care to patients, not because I'm worried about myself, but because I'm worried about them. And that has been quite an issue. I also noticed that Dr. Seibold has made a clarification about advocating for paramedicine not to be a replacement, but a complement to our services. There's a lot of very interesting work going on right now about filling that gap of sort of emergency work or acute or urgent care work in the home, where home health isn't really set up to do that regulatorily or from a policy perspective. But there's a big gap there, and it's really exciting to see some of the work. I know we're not supposed to mention companies, so I won't mention, but I know there's a company that's doing some very exciting work based in Denver, Colorado, that hopefully is up and coming. Otherwise, I appreciate the opportunity to chat with you all and learn from you all today.
Thanks, Brent, for your insights. Appreciate that. Ken, and I know you want to talk about PPE a little bit, so please.
Thank you very much, Rick. Again, my name is Ken Albert. I'm president and CEO for Androscoggin Home Healthcare and Hospice, and that is I'm the token East Coast representative here on this panel. I'm up here in Maine, and Rick, I'm happy to take a conversation offline with you about the work that we're doing throughout our region with ER, EMS, and home health nursing. We're actually embedding personnel right in emergency departments. We also are using our health information exchanges, making that available for emergency providers in ERs to see what's going on for home health, hospice, and palliative care patients in the community. I do want to talk about PPE briefly, and as Brent said, Kathleen, he and I serve on the National Association, so we got pulled in very quickly into the national dialogue around PPE. I was also formerly in another life, I was head of the Maine CDC, and so was familiar with management of government stockpiles of PPE. And what I began to realize very quickly as information was being exchanged between the federal government and the states was that the tiered distribution and priority validation process for PPE excluded home healthcare and hospice providers. And it's completely an oversight from our federal government, but it began to be a significant issue across all states. And so the 4 tiers of distribution, the bottom tier being non-clinical, first responders, fire department, and police department, there's no other category. That tier 1 is hospitals and EMS providers. There was no other, in the other categories, we didn't fall. So we had to begin advocating very, very quickly with our public health departments, with state governments and with federal governments about, hey, wait a minute, we're seeing 50 to 60 million patients a day across this country in home care and hospice. And in Maine, I'll speak for Maine, we have also been tracking, because I needed to advocate for PPE for this industry. We were tracking the number of patients for all home care and hospice providers in the state as compared to COVID positive patients in hospitals. And I think rarely did hospitals surpass home care for the numbers of patients we were seeing, either PUIs or positives in the home setting, absolutely taking care of post-discharge COVID patients. So we're beginning to work at the national level. We've been working since April with the administration and also with Congress to identify language that would insert home care and hospice providers within the ambit of the tiered distribution process. And then all states are taking different actions as well to ensure that public health departments or state governments are including this particular industry within the PPE distribution. That's really what happened at the outset. That's why you saw pictures of nurses in New York City wearing trash bags and makeshift masks taking care of home health patients, because we were not on the distribution channel at all. And the private distribution channels were inundated, obviously. And then when the government stockpile distribution channels didn't include us, we were just left out in the dark. But I think what you'll see across the country is most home health and hospice providers now do have sufficient PPE. We're managing our own stockpiles internally. Linda, 6 months. I think a lot of us are in that category now at this point. And so I appreciate the opportunity to opine on that. And I just want to, if there are any other states listening to this who have not been navigating language within your states around how to include home care and hospice in PPE distribution channels, I'm happy to speak with them.
Yeah, Ken, and one thing as you were mentioning and trying to figure out or talking about, making sure home health has some a different level of visibility than it might have otherwise. For awareness, actually making sure we did a rounds on this. While I've always thought about home health and thought about long-term care and so forth, so on, this was actually pushed from HHS's healthcare resilience work group team to me. So it's not from, okay, so as a Fed, I could tell you, yes, this is on the radar screen in a way that I would not have expected otherwise, in a positive way. So I think that that's all good. And thank you for your comments, particularly around the PPE stuff. Huge for all of us. One of the things that we've found on rounds is the thing that will help healthcare providers the most, and including long-term care, home health, et cetera, is making sure they have adequate PPE available to them. And that's going, we all know that. So I'll turn it over to Dan Gerard, then Dave, then Harry. Dan.
Thank you very much. What an excellent presentation. I'm Dan Gerard. I'm with the International Association of EMS Chiefs. The interface, support, and interaction between home health care providers, long-term care providers, and skilled nursing facilities has always been tenuous at best. And so, you know, there's a lot of logistical, operational, and clinical issues where we all intersect. And if anything, the COVID pandemic has seriously highlighted that. I want to take this opportunity to reach out and start those conversations so we can start working on those things to improve them for the future, because, you know, there's always going to be another emergency down the road. I have two questions. Did you have a clinical pathway for treatment and management of the COVID patients that were diagnosed as COVID, or that you were determined to manage in the home healthcare setting? And how did you communicate that back to your EMS providers so they knew that at this point in time, you know, we were going to reach out to you and move this patient into a hospital? And thank you very much. Excellent presentation by both ladies.
I'll let any one of the home health representatives take that by raising your hand. Kathleen? I think you were raising your hand. Yeah.
No, just unmuting. I just
Okay.
have a few of my team members in the room with me. And for us, not so much the hospital that we're affiliated, the primary anchor hospital that the agency is affiliated with, there's 3 hospitals, but the primary one, that was the major source of communication with EMS. And to your question about care plan, no specific care plan, because all the care plans follow your primary condition. So for COVID, it was an infectious disease condition with all of the sequelae that we're all aware of, and therapists and social workers, whomever would follow that with all of their PPE for droplet precautions. So not so much a care plan.
Thank you. Dave Gerstner.
I don't have anything to add. I think that the comments about community paramedicine filling a very different space than home health care were well made by Harry, and I agree with that completely. That's to go along with what Dan said. That's a gap that we probably need to close. We need to get home health working with the community paramedicine developing groups. And that's something that we have not done in my region. We have a regional committee that's working on this, and we've invited everything from payers to hospitals, but haven't invited home health, and I will rectify that. So some great presentations, great comments, and I thank you all. That was very worthwhile.
Hey, Dave, it sounds like you got to update your to-do list, obviously. Okay, Harry?
I just wanted to thank the presenters. It was fantastic. And it just seems to me in my world that we've had much more attention to home health and to the role they provide and things like care plans than we've ever had in the past in emergency medicine and in EMS. I have just one question about to any of the panelists. If you see new roles or new processes for home health as we go through what I've heard starting to be described as the twindemic that is on our horizon with the influenza season overlapping with COVID. I think there's opportunities there, but I'd be interested in what the panelists have to say.
Anyone want to take that? Yeah, Ken?
Yeah, it's a great question. We're actually working at the national level right now following the sentiments stated earlier about, you know, the desire for people to remain in the home as long as possible and outside of facilities, largely because of visitation policies and so forth. Choose Home, Linda mentioned that earlier. That is actually a program that is being launched. We're in discussions right now with CMS about actually, it would be a skilled nursing facility level of care provided by home healthcare companies, providing skilled home health in the home. That's that's been kind of evolving over a period of time, but this would be a wholesale shift. And it would be an option for patients being discharged to either go to a skilled nursing facility, or home health providing skilled nursing facility level of care in the home setting.
Thanks, Ken. Appreciate that response. I'm going to turn it to the final word to Linda, and then Kathleen, if you want to come on that, and you get your final word too. So Linda, please.
I would just echo what was just said, a lot of what was said. I do think in a very strange way, COVID has brought home health more to the forefront of the healthcare continuum. And so it's being recognized that the services we do and keeping patients safely at home is a huge piece of the continuum. And I do hope that as we go through, I know we have another year on the horizon of this, that we work together, but be it with our EMS or our other healthcare providers, that we find ways to collaborate and work to keep people at home. And that's where many people want to still be, and it is definitely more safe for them. So thank you for this opportunity to share.
Thanks, Linda. Kathleen.
Yeah, just a couple final thoughts. One of probably the purpose, right, for home care organizations is that we get out there and we get into the community and we get into the homes. And with that responsibility, I think we need to shoulder a mantle to be far more creative, perhaps, than we have been going into this next year. And with efforts to address the social isolation that our seniors continue to experience, and it's not getting better. We do innovative things like a number of our nurses here were trained to do the collection and have gone around to all the skilled facilities and assisted living facilities as requested, because again, the lab associated with the hospital was very visionary, and testing was far more available and quicker so that we could keep workforces going and help manage the first SNF outbreak that occurred. We were there. Those are important roles that we can do because we're out there, we're mobilized. And there's an emphasis, I think, we all know that the social inequities, the disparities that do occur, when you care for communities that have high density housing, socioeconomic challenges, it behooves us to pay close attention and be good stewards and supporters of our patients that live in those communities where we have seen the impact of COVID to be particularly more challenging.
Thanks very much, Kathleen. Yeah, 5 minutes over my projected 1:15, but it's been a really important conversation. The presentations, the conversation among the panelists, and goodness, the chat, wow, lit up pages of chat for sure. I think it actually served the purpose I thought it might, with bridging some disciplines that might not talk together nearly maybe as regularly as they could or should. So most grateful for our participants from a broad sector. If it's anything like the other rounds, once we do like follow up and figure out who was on, a broad range of disciplines participate on the rounds. Thank you very much for your participation in the chat and the polls. To our panelists, just great. Particularly thank you to our home health panelists, and to those panelists I invited from the other disciplines who made this much more than a singular discipline conversation. To echo, awesome. And to our speakers, many, many thanks for your contributions to our collective learning, peer-to-peer learning platform. With that, we'll see you on the next one. Take care and bye.
Thanks, everybody.
Thanks, everyone.